Welcome. Thank you for joining us today. I'm Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General.
And I'm Stephanie. I'm a public health intern here at the Blum Center.
Before we get started, just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you're in listen-only mode. Everyone has mute so we can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. So next, I'm going to turn it over to Stephanie, who will introduce today's guest speaker.
Welcome, everyone. So today we have Dr. Lin, and Dr. Lin is a medical geneticist at Mass General for Children in Boston, Massachusetts, who is passionate about the multi-specialty care of people with rare syndromes. She is the co-director of the MGH Turner Syndrome Clinic and MGH Meyer Syndrome Clinic. Dr. Lin also sees patients in the Hereditary Hemorrhagic Telangiectasia HHT Center. She has additional interests in Soto syndrome, Costello syndrome, Charge syndrome, and the MN1 C-terminal truncation syndrome. Regardless of the disorder, families and providers benefit from the communication within their team and networking outside to expand their knowledge base. Dr. Lin today is going to give a presentation on how to coordinate care for a person with a rare genetic disorder. Please help us in providing a warm welcome to Dr. Lin.
Thank you for the introduction. Hello, everybody out there. I know that currently it's a very small group, but I hope that as this is recorded and viewed later on, it will reach more people. This topic may seem to be mostly about children, but increasingly, the world of rare genetic disorders that we deal with in genetics is extending across the lifespan. So I'm framing this as coordinating care. How do you pull it together if you have a child or yourself has a rare genetic disorder? And to disclose, I also do work with the Department of Public Health. I'm a consultant for a program that looks at birth defects. I also on the editorial board of a journal called the American Journal of Medical Genetics. I serve as a consultant for the Myrie Syndrome Foundation. I'm also on the board of the Turner Syndrome Society. These are organizations that I work with. And the purpose is to say that whether you, your child, or a patient of yours has a diagnosis, you will already have care in the disorder at a specific clinic or maybe seeking care. And if that's the situation, you're in pretty good shape. But I'm going to discuss the importance of creating a medical health care plan, share ideas to do this, make it a deliberate process, create a team, your personalized team. Think of this as a pep talk. It's not a lecture. What works for me may or may not work for you exactly. You're going to have to develop your own playbook. I always use the analogy of baseball, my favorite sport. And working with families to me is not top down. We're a team, we're on a field, we have parents, we have patients, we have PCPs, we have specialists. I'm sort of in the corner as the manager trying to help coordinate everything. And again, this might apply to somebody with a non-genetic disorder, but I'm going to focus on some genetic ones in particular. And so let's talk about what it means to have a rare condition. What does it mean to get your diagnosis? And so parents will tell me it is like a tidal wave, a tsunami. It wipes you out. It's like a door slamming in your face. Some of the hopes that you had, they're gone because now you have a diagnosis and your heart is broken. And for many people getting there, it's a tortuous process of getting to doctors at a major hospital such as MGH. And for many people getting to that space, the diagnosis, after you get over the shock, it's actually kind of peaceful. You are in a safe harbor. They found the needle in the haystack. And for many people, it helps solve the puzzle that represented you or your loved one. So how do you start by getting information? So I'm going to tell you about a syndrome that I'm passionate about called Myrie syndrome. the doctor who originated. She's Scandinavian descent. Some people pronounce it Mir. So one of the things you can do for genetic disease is you can just go to your search engine, you can just type in the disorder, and a whole lot of things will come up. So AI will actually do a little summary now, but a common one that we use is called NORD, and that has to do with National Organization for Rare Disease. Or you can go to a support group. All right, so somebody is out there who has a child with a rare syndrome, you go to the support group. So we have the Myri Syndrome Foundation, and there's good literature, there's good teaching videos, there's a lot of education. And then we have, say, my own clinic. And so this is my website at Mass General called the Myri Syndrome Clinic. It's got pictures, it's got access. In other words, this is how you start. You go online and you start for the best resources. You need to build a team. You need to get a coach. Again, this is my role. And again, I'm sort of focusing on genetic diseases, but it could be other complex ones. Everybody needs their home base. They need the PCP, the primary care practitioner, pediatrician, or family doctor. They will provide health maintenance, vaccines, measure growth, check development, care for common illnesses, refer to specialists. And it's easier if the PCP and specialists are in the same center. And I'm not trying to advocate for just MGB, but I can tell you it is a lot easier because you can communicate freely. Now, you need a healthcare coordinator. And if we're talking about a child, it is the parent. It really starts with that. And parents might feel really overwhelmed, like, how am I supposed to organize things? I'm just learning about this. And so that's the reason you sort of expand the team. And so there's a clinic model which supports the PCP, or sometimes the PCP is the leader. So let me say that again. There are some disorders for which are so rare that the PCP says, I'm going to let the clinic take over. I'm going to let the Myri clinic take over. But there are others where the PCP will say, I feel pretty good about this. I'd like to be the leader. And I show this mirror because I'm turning it back to my audience who's looking at me, listening to me, the parents and the other doctors. Okay, so it's sort of a dynamic I'm trying to create. So one of the ways to think about care is think of a Venn diagram. We all learned about them in elementary school. The PCP is at the center. But then you add in me, genetics, and other specialists. Okay, I'm just flipping to show you some of them. This applies to, say, Myri syndrome, very complex, a lot of these other doctors. And then you can have a variety of even other things. So I've listed other specialties, skin, GI, eye, joints, etc. And this is me down the bottom. I mentioned I could be like a manager, kind of like a captain of a ship. I'm trying to help steer the ship that has other people on board. Again, this is a team. So you might say to yourself, well, wait a minute, couldn't just one doctor provide all the care? And I've kind of mentioned that some PCPs want to do it. But the trick is it's really a challenge, and it's a challenge to provide all the care at every age. People are getting older. So PCP, by the way, refers to a primary care physician, a family doctor, GP, pediatrician. And I'm going to show you the team that we have for the Myri Syndrome group. One of the key members is this gentleman, Matt Thompson. Matt Thompson is a PCP who cares for some children in Spokane, Washington. And he is a valuable resource. He will tell us, well, you guys are a little bit off on this. Let me contribute that. So he is a PCP who has confidence in taking care of some of these kids, but he himself knows that he needs a team, okay? So for many, there is a syndrome-specific team already, and that's kind of nice. You don't have to create one. There's one already. And so you could go to the website for my division, Medical Genetics. You'll find all these conditions listed: Down syndrome, HHT, I know it's a mouthful, hereditary, hemorrhagic, telangiectasia. Then other conditions, lysosomal storage, Myri syndrome, this is mine, Pitt-Hopkins, Stickler, 22q, Turner syndrome, Williams syndrome. And I must brag a little bit. I think this is what my group, our group does at MGH so well. We have syndrome-specific clinics. We follow people across through the lifespan, through all ages. And as many as are listed here, there are twice as many. And so we have a genetics program. And I'm going to show you an example of how we sort of organize a team. A team is organized by a leader. In this case, for me, it's I'm the leader of the Myri syndrome team. I call people and I'll say, we are going to be following people who have this condition. I need pediatricians. I need adult specialists. And so my photo directory has this lovely list of all sorts of doctors. I have a similar photo directory for Turner syndrome. Same approach. You need a leader, you need a core, you need children, pediatric doctors, you need adult doctors too. And this is the Down syndrome team. much larger than Myhre syndrome, but the same idea. And this is sort of what we do here at MGH Genetics. And we have shared values: a leader, team members, overlapping interests, patient and parent advocacy, part of the team. There's variation in funding. Often we rely on philanthropy, the generosity of families, friends of families, some grant support, and sometimes it's really all about volunteering. Doctors are not paid to organize these clinics. We are doing this because it's part of our careers. This is what we like. So again, getting back to Myhre syndrome, it's not only what I do in Massachusetts, in the United States, but beyond. And so what I have done is try to network to people around the world. And you can see this map of the world, and you can see that we have clinics here. Let me see if my arrow works. These are clinics that provide cardiogenetic care. There's one at Stanford. We have Canada. These are where the board members live. We have genetic departments around the country, Europe, and even Asia. So it's important to us that we provide leadership around the world. So a genetic diagnosis helps. If you are somebody listening who has a child or yourself, you have something, but you don't have a diagnosis, I would strongly encourage you to do so. Having a diagnosis provides an anchor. It provides a magnet to get people to help you. I've met people who have children who do not yet have a genetic diagnosis, and they're hesitant. They're hesitant to go to the geneticist, and the reasons are complex, but I will encourage you to do so. So this is an example of another disorder I work with called Costello syndrome. And you can see I like to use a lot of visuals. So here's an example of how we provide care for children. Again, you have the core, then you have the specialists going around in the circle, okay? And so you have to work together. As somebody gets older into adult age, some of those issues change. Some of them become less important. Oncology, cancer becomes more important for Costello syndrome. So care changes over time. And anybody listening who has a child or themselves with a rare disorder, you feel this. You will come to us in genetics and say, I need help. I'm just not getting the kind of support that I need. It's probably here at Mass General. It's just a matter of sort of mobilizing it. So there is a model of coordinated care I call DIY, do it yourself. And I'm showing the mirror again to reflect somebody. And again, somebody might say, look, I've got a good PCP. I live in a small town way outside of Boston. I'm going to try to figure it out. You know, good for you. And then other people, though, will say, I need some help. So one of the things that MGB offers is there is a disabilities program, and there is a wonderful person there named Karen Turner, who's called the Patient Navigator. She focuses mostly with autism. But so there is somebody to help you literally navigate this big hospital if there isn't a clinic already. So the do-it-yourself model, as I call it, means the parent or the patient is the teacher, the preacher, the guardian, the enforcer. It's a lot, isn't it? And I say, and parents will say, gee, how can I teach my doctors? And I'll say, you know stuff, and we're going to help you learn more, and we'll help make it sort of a dynamic interaction, but be proud of your role, and I salute you. I hope there's some people who listen to this who are shaking their heads saying, yes, I know what it feels like. One of the things that happens with rare diseases is we have rare and ultra rare. And then ultra rare, there are people who they're the only person. They're the only person with a particular gene defect, chromosome problem, metabolic problem. We care for people, and we try to figure out a customized program. So here's an example. Even without a genetic diagnosis, there may not be a special clinic for your syndrome, especially if the person is an adult. So you have to sort of improvise, and this is the doctor and you have to improvise, you have to be flexible, you have to see what you can figure out. So I was referred a 42-year-old woman who had a rare syndrome called Cornelia de Lange. Cornelia de Lange is very common to every geneticist, it's kind of bread and butter. Severe intellectual disability and autism. Many years this person spent at hospitals in the area, Boston Children's Hospital, the Franciscan, relatively healthy, has some issues with kidney infections, anxiety, living with aging parents. And that is a key factor. Not only do you have an older person, but the parents are also getting older, and their medical needs may be increasing too. There was a brother, lived out of state, and he had contacted us, and he said, couldn't you do something for me? Well, it turns out that at Children's Hospital, there is a DeLon clinic. There's a Dr. Phil Boone who leads one. I care for adults. I don't have a DeLon clinic, but Phil called me and we said, let's figure out something. Let's improvise. And this is a picture of Phil over here in his clinic. So we made referrals. We figured out what needed to be done. We actually admitted this woman. She needed an MRI, and it was a success. We were able to work together and improvise. She eventually returned to her parents' home and is relocated to her brother's home. So this is a success story. It doesn't always happen that way. Now, what if there's no personal advocate? What if you can't find somebody, a geneticist, a neurologist? You could attend a national syndrome support group meeting. What does that mean? Suppose your child has a condition with, I'm just going to say a rare skeletal problem, and you have not been able to identify somebody at MGB or in the Boston area. You probably should, but you may not be able to. Suppose you find out that there's a national meeting happening in Washington. You can go to these meetings. You can take your child or yourself. There are experts available. They won't be able to do a full evaluation, but they at least touch base with you, and that's a start. And again, I'm just trying to give you some creative ideas. For example, there is a Cornelia DeLong support group meeting where people will go. They'll meet some of my colleagues. Or you can go to a coordinated care clinic. So this is the notion of specialists led by expert pediatricians. They're fantastic, and they will provide care either because you or your child has a rare syndrome, there is no clinic, or because you're in the process of getting one. And so this is the notion is called primary care collaborative. And MGH has for pediatrics, the pediatric coordinated care clinic. There's also something called ICMP, which is coordinated care, medical care in general. And it's the integrated care management program. And all these programs begin with a website. You know, you go to the website, you click around, there's usually something that says, please contact us. So these are some of my interests outside of the main ones. These are rare syndromes. I may not even go through all of them. Some of them have names like Soto syndrome. Some of them have a gene like MN1, Costello syndrome, charts. These are easy to remember. Some of them are long, BOFS, Gorlin syndrome. Others are sort of a general category of vascular. So I do not have clinics for all these disorders. But if somebody were to contact me, I apply my leadership and my role to come up with a plan for the person, okay? So one of the things I always mention is you may wonder, how do doctors know how to do what they do for a person with a special disorder? How do you come up with the idea of a plan? And it begins like this. Every doctor begins with the first person. You know, you think, well, in my experience, and some doctors will actually report, we call a case report. Then somebody might say, you know, I've had a couple cases of such and such. I kind of understand it a little bit. Some people report that in the medical literature. We call that a case series. And then when things get larger, when you have more patients, doctors will do studies. Like my Myrie syndrome clinic is a large cohort, and we reported 47 patients in June. If you have a really large group of patients, now we're out of the realm of rare syndromes, I'm moving along as a teaching point, you can look at the whole population. And sometimes if you have a drug, you can compare people are taking the drug or not. It's called randomized control. And finally, what you do is you get all of your experts together, you come up with criteria, you write a paper, it's usually in the public domain, they are the guidelines. And at the very best, we call them evidence-based guidelines. So I'm going to give you an example. And again, I'm using some syndromes to illustrate what we mean by guidelines. So for Costello syndrome, I was part of a group here, and we wrote about the appearance, the genes, the management. And so a parent, these are in the public domain, could find this and look up, what do we do for Costello syndrome? You want a doctor leading, but you can start yourself. This is something called Turner syndrome, and I'm part of this international group, and we have a clinic here. And again, people got together, they came up with guidelines. Guidelines are not rules, by the way. So if somebody says, well, you should check a certain blood level every year, and they forget, and they do it every 2 years, it's not that you've broken a rule. You're giving people guidance. So there's some flexibility. And for Turner syndrome, what's really cool is we not only have the doctor version, which is 90 pages, but we have a patient family version, which is on the website of the TSSUS. So that's kind of nice. And this is another disorder which is familial. It's not something that I work with, called 22q11.2. Very common, also known as DeGeorge syndrome. This is something called mitochondrial disease. One of my colleagues, Amel Cara, is a big player in this, and they got together, they came up with a statement. So I hope this helps you. It's not just what the doctor has learned personally based on 1, 2, 3, 4, or 5 patients, but you look for these articles that really summarize the world experience. So a concept that I've been talking about is this idea of care across the lifespan. And the lifespan actually begins in prenatal life if a fetus is diagnosed. Neonates, toddlers, children, preteens, teens, young adults, and adults. I did say, I'm sort of bragging a little bit, that I think that my programs really hit this sweet spot. Okay, you often have care for children, but you often have difficulty once the kids become teens, young adults, and into adulthood. And what happens is the needs, the discussion changes. So when you first meet a family who has a baby with a rare condition, you'll talk about the diagnosis, the heart, breathing, ears, growth, behavior, and development. But as people get older, things change. You're starting to talk now about school, peer relations, puberty, and then into adulthood, things change even more. These are the things that adults have to think about, like coronary arteries, like cancer, like career, like independence. But these change over time as research provides insights, or we know we have answers to some and we can revise them. So I have these couple little visuals to say, as kids grow up, care changes across the lifespan. Here's a little graphic. I have a couple of these that show you a preschooler follows rules, separates from parents. We talk about a young adult. This is a senior, manage health issues, cope with losses. And most of you who are listening to this should be shaking your head saying, yeah, I understand. You might be in this group, you might be in this group. Here's another illustration showing you a woman, and this is going through her natural history into the senior years. And this is somebody who has Williams syndrome. So Williams syndrome is one of these rare disorders, and my colleague Barbara Pover provides cares into adulthood, which is pretty exciting. So I'm going to talk about what I call toolbox. What are some of these things that you can use besides the people? So you have to sort of get into the idea of looking online. And if you do become a patient at MGB, we really advocate what's called a secure portable patient gateway. So of course you could write me an email saying, Dr. Lynn, what's the telephone number? That's not really patient related, but once we talk about your issues, glucose, chromosomes, personal things, you need to be in a secure environment. That's patient gateway. And we have the ability at MGB, we use a type of medical record. I'm not promoting this, it's just called EPIC. It allows us to not only see the medical records at MGB, but at companion hospitals, institutions that also use it. And that's really a big plus. So low-tech toolbox are things like faxing letters, reports, surface mail, a phone call to your PCP or specialist. But you will find most doctors like me really prefer patient gateway. It really facilitates the communication. Keep a calendar. I know that seems so basic, right? We have calendars on our phone. I advocate something I do for myself, a giant calendar in the kitchen right next to the phone so you see it and you can put down your visits, etc. Keep an address book. Use the camera on your cell phone to record things, to show me pictures of your children. You do need to have some computer capacity. It could be a computer, your laptop, an iPad. And virtual visits, when we practice telemedicine, require that you have some capability. Sometimes the things that I use that are low-tech are a tape measure. Measure people's head, their height, a scale to talk about weight. Do a blood pressure monitor. You can use them for at-home monitoring. So what's in your locker? One of the things I talk to people about is you have to start early on managing your reports. You might get an after-visit summary, you take it home, you toss it. But start a little filing system. It could be a folder, a big box, a drawer, an accordion folder, things that you get at, a store. You want to download things from the portal, scan to your computer as electronic files. I know I'm getting a little fancy, but this is the way to manage it. And ask your providers for copies of their reports, okay? And then share your reports. So if you're seeing all the doctors in an MGB system, we can see each other's reports. But say you move to another state, whole different system, they may not be able to loop in to see what we've, written about. You have to fill that role. I'm sorry to say that. That's why I ask people, get the records, make copies. If you have to move, you have to share, you have to start all over again. And medication management comes in different forms. So a lot of pharmacies now have auto renewal services via text message. You want to check your medication bottles to make sure you know how many renewals you have when it expires. And contact your providers. I'm getting back to the secure email again. So I want to talk a little bit about self-care, because one of the mothers to whom I gave this talk said, Dr. Lynn, you've got all these great ideas, but you realize you need to know that the parent of an extra needs child really doesn't rest. Severe autism, severe intellectual disability, severe medical problems. And so this is a mother of somebody with Myhre syndrome, and she, cautioned me. She said it's a special form of exhaustion. You're never fully rested. And she said some tips for the providers: just remind your parents that they're doing a great job, they're not failing. Listen, provide respite somehow, give them a break. Ask how the patient's doing, but ask how the parent is doing too. Just sort of recognize them. The frustrations that parents have said is there's so many providers, so difficulty scheduling. It would be great if I could see patients at least 2 on the same day. You got to be a strong advocate. And she expressed a feeling that parents have, I've got friends, family members, but they don't always get it. Sometimes I have to explain all over again what's going on, and I get burned out myself. So I advocate that people share their story. So this is taking a leap. This means going into YouTube, the public domain, and I can see why people don't want to do it. But there are some advantages. I always say you own your story. You show your child in their best light, in your kitchen, playing, dressed up, instead of just a picture in a doctor's office. So own the story. This is the a young man that I follow, and his mother had an interview. Shows him, he has Myhre syndrome, but here he is at his job. He's got his caring dog. So this is him at his very best. And these are stories that are on my website. So people who are interested they want to show the world, this is how we are living. You can find that on my Myhre syndrome website. And you become a magnet. So if you allow yourself to be out there, people will find you. You become a magnet, which can be very positive. These are people who have Turner syndrome. This is the Turner syndrome website. And again, these are people showing themselves at meetings, hanging out with friends, trying to inspire others. Share your story. So in summary, I'm going to say that creating a healthcare plan is a great goal. In other words, thinking deliberately about how you're going to take care of yourself or your child. It takes effort, flexibility. If it is a disorder that might be genetic, the diagnosis really helps. And we have all sorts of ways of testing. You may have heard of chromosomes, something called sequencing. We have a lot of tools. You have to be willing to do it. Doctors won't say, you have to do this. You have to be willing to say, this matters to me. But I appreciate that there's different strokes for different folks. One size does not fit all. These are just suggestions. Somebody might come back and say, Dr. Lynn, that did not work out for me at all. And I like that, because it gives me another idea. I'm only giving you my suggestions that most of my patients have strongly endorsed. And then I always say, it's this idea of, I say, you have to be not only the teacher, but the preacher. So if you have learned something, pay it forward, right? Share your know-how with a person, your family member, a genetic center. Go back to some of the doctors and say, listen, this is what we're doing. And hopefully the doctors will appreciate that. So in addition to clinical care, I do want to put this out. Consider participating in research. Provide personal experience and data. We have lots of research at MGH. This is one of the things that we certainly are known for. And I do this in my clinic too. I always say to my patients, if you're looking for answers, try to be part of the solution. It might be as simple as saying, well, what do people with this syndrome look like? Is my child the same or different? Are there more males? Is there a specific genetic mutation? Can we figure out anything to predict the future? So these are fairly simple questions. And if all goes well, with more information, more research, possibly even therapy, we will find the end of the rainbow and find a pot of gold. And this is one of my patients whose mother proudly let me share this picture. All the pictures of these individuals have been consented formally and have been shared by their families. So I always thank the families who inspire and teach me. the professionals who are part of my world here at MGH and around the world, the geneticists and genetic counseling counselors here at MGB, friends and family who supported my programs. You know, I do need to rely on contributions, MGH Fund Development, referring physicians. And I always say to my families, you are our teachers, not really our patients. It's up to us to ask questions, to listen, and to learn. I share this. These are two patients that I care for. This is a woman who likes to blog. She wrote a blog entry about sitting in silence, well, almost, and what has reminded me about hearing loss. It was meant to be a funny story. She talked about having her dog Lucifer catch her hearing aids and having the dog destroy them. But she reminded me how important it is. She said, I wear them until they are at death's door. She said there will always be an adjustment period. And she said, if your kid does not want to wear his or her hearing aid, pay attention, and everything is adjustable. So she is talking to the world of Myhre syndrome, but I'm listening because she taught me things just in this little blog. This is a video. This is a grab from a video. This is the mother of one of my patients, and she's talking to her son who has Myhre syndrome and hearing loss, and she's reminding me about how to sign. And so I'm learning from her. And that would be the end of my talk. I'm going to pause now. I think we are good for time. We have plenty of time.
Thank you, Dr. Lynn. We're now at the end of the session. If you have any questions for Dr. Lynn, feel free to do so feel free to share them in the chat. Dr. Lynn, we have a question regarding the coordinated care clinic. Would you be able to share a little bit more about that and whether something like this would be available to patients outside of Mass General, or is it unique to Mass General?
A very good question. Currently, it's designed that you need to have an MGB pediatrician. And it's really not about playing favorites. It's about communication. So this group they're fantastic communicators. They're fantastic doctors. So if you have an MGB pediatrician, you just go to the website. Everything is web-based. I don't even need to give you a phone number. You would just query that. And there's probably a link that says, if you're interested, contact us. And somebody did put down the, oh, you did. Thank you so much. You put down the medical genetics website. And so any other questions?
We do have a question on, for people who may not be an MGH patient, what
Yes.
online resources do you recommend on care coordination tips for people with a genetic disorder?
You know, I'm not exactly sure. In other words, to be honest, I focused my talk to, number one, people who might have a genetic problem, but this could translate to something else. Number two, the benefit of getting a genetic diagnosis, and there is a question about that. And the way people get that is you have to get a genetic consult. Either you've had one at another hospital, children's, or wherever, another country, another state, or you need to start here. You need to get a diagnosis. But when I say need, by the way, I don't mean to be too forceful. I'm saying it really helps. Depending on what the answer is, that might be a direct segue into a group. We might already say, oh, you know, as a matter of fact, we have Dr. So-and-so who follows people with that disorder. If not, though, we're sort of in that realm of improvising. You'd work with your geneticist to create sort of a team. I'm going to make sure that I've answered that question adequately. Oh, for people who do not have a pediatrician at MGB, there are resources, and you sometimes have to just go out to the internet and check some of them. You can certainly be seen here. I hope I haven't misspoken. A person who is a pediatrician elsewhere certainly can come and meet me. Absolutely. I was referring to the coordinated care program. Okay.
Thank you. And to follow up on some of the information you shared just a moment ago, what tips can you share on where to start for parents and caregivers of children with a new genetic disorder diagnosis?
Okay, so I'll make it easy. I'll pretend that I'm your doctor, and I would say we would meet after the diagnosis. We would have a session where we would go over what the diagnosis is, what is known about it. I would teach you. I would tell you what resources there are, and I would tell you if there is a community. By community, I don't mean just a support group, whether there are 50 patients, 500, or just 2. And that's where we would begin. If you are somebody listening in and you're from outside of MGB, you just backtrack. You go back to your geneticist. You have to ask them. I will tell you that different providers have different styles. Many doctors, I can't speak for any in particular, their focus is, I get the diagnosis. Now I need to let the pediatrician take over. And that's sort of the challenge that I'm telling you. Our role at MGH, at MGB as geneticists, we do try to take over, at least starting the process of getting the care going. So we don't fill the role of a PCP. We don't see people every 2 weeks. I might see somebody every 6 months, every year, every 2 years. But I'm trying to be like a guide.
And with that, do you tend to be in close communication with the PCP?
Absolutely. My letters, every letter that we write begins with referring who made the referral. Sometimes it's the self, it's the mother, it's the person, self-referral. Other times it came clearly from the pediatrician. Sometimes it comes from a specialist like a neurologist. And the letters that I create begin with, "Dear so-and-so." We have the ability to send out what's called a care team. So you not only send it to the pediatrician, but you send it to the other doctors. And because of the medical record system that we have, people can actually view many, but not all of their reports. Mine is available. You can go into the gateway, you can go into the portal. It's like taking a dive, going through doors. You go down to the part that's called the visit, and you can see the note. I have to tell you, it doesn't apply to everything, but it would apply to my note. So after you meet me, wait a couple of days, you'll go back and you'll find that and you'll go over what we talked about.
Thank you. So while we wait to see if there are any additional questions, are there any final thoughts you'd like to share with the audience, Dr. Lynn?
I would like to know if anybody would be willing to disclose if they are working with or have a particular syndrome, because that would allow me to have a specific example of how to help you. I don't remember, this is anonymous, but it would help the discussion if I knew that. I'm just going to see if anybody replies. Thank you very much. I don't know if you know that your name is showing, but there is a person who's talking about Rubinstein-Taybi syndrome. And that is a familiar syndrome to geneticists. We know about that. We can recognize that there is a support group. I don't want to cheat and go online to see what's available there. And I don't know if there's a community in the in Massachusetts or in Boston, but that is a familiar disorder. And to the person, I don't know if it's the mother or the person, if you have any questions about it, you're welcome to come and see me as a doctor-patient relationship. I must tell you something. Unfortunately, because we are well-respected and popular, it usually takes several months to meet us. Certainly, if there are emergencies, we find a way. But for many of us, there's like a 3, 4, or 5 month delay. And it's really only because I think we are being seen by many people. We're not inefficient. There's just of high volume.
Is a referral generally required?
I'm sorry?
A referral generally required?
Generally, but as I said, a patient can make a self-referral. Somebody could call my office and say, I heard Dr. Lynn give a talk. I have a child with RTS. I think I'd like to meet her, or maybe I'd like to meet somebody else. Or I live in Maine. Maybe you have a suggestion for me. That's the way we can help you sometimes. The only thing we can't do, and I should clarify, doctors cannot provide care if we haven't met somebody. So somebody can't call me and they do, I have a daughter with Myhre syndrome. Do I need to have this test? And I'll say, well, I can't really do that, but I can tell you, here is a resource online where you can take that to your doctor and discuss it. So we can educate and we can coordinate, but we can't provide care.
You brought up a great example. Like, what if a patient, family, they live in Maine, they do come in for some initial visits. Are you able to then continue the care virtually?
Great question. Thank you so much. So generally we would say, if somebody called me and they would like to meet me, I would say, I need to meet you. We need to just have a face-to-face visit. Then for follow-up, if it's a situation where we sort of get our plan going, we now just have to see if it was executed, we could do a virtual visit. I do not have a license in Maine, so we can only do that if you have a license. But some of my colleagues do. So sometimes there's some flexibility, and I would say, hey, would you mind seeing so-and-so, because they do have that ability. You can do a virtual visit if you are in the state of Massachusetts. If this person who I met for the first time lived in Massachusetts, no problem. There is a way in which we can see a patient. They have to be physically in the state of Massachusetts, physically in the state. I won't say any more about that, but there are ways to sort of make it work. Was that your question or was that from somebody asking?
I was just asking on behalf of anyone who may be curious.
Mhm.
All right, so I don't think I see any additional comments or questions in the chat, so I think it'll be fine to end a few minutes early.
I appreciate all the questions. I feel that you made it easy for me. These were things I was trying to address. It let me know if I didn't address them well enough in the discussion, and perhaps I'll meet some of you later on. So thank you very much, Blum Center.
Thank you, Dr. Lin. And for everyone who joined, thank you so much. Hopefully you found today's session helpful. As I had mentioned, today's session is being recorded. It'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Take care.